So, what happens when a common symptom like shortness of breath suddenly becomes a real medical emergency? In this explainer, we're going to follow the critical journey from a patient's first complaint all the way to a life-saving action plan. It's a fascinating look at the systematic process healthcare professionals use to solve these incredibly complex puzzles.
Okay, so let's jump right in. This is Mr. Granger. He's 67, and he has a known history of COPD, chronic obstructive pulmonary disease, which makes it really tough to breathe. And for the last 3 days, that difficulty has gotten severe. So we're going to follow his story to see exactly how a complex respiratory issue is broken down and managed, step by step.
So where does this all start? Well, it begins in the primary care office. It starts with those initial symptoms that brought Mr. Granger in, because he and his wife were really worried that something was seriously wrong. So, what are the first pieces of this medical puzzle? Well, Mr. Granger and his wife tell the clinician that he's been getting more and more short of breath for about 3 days. He says it feels like a cold that just won't go away, and his wife adds that he's felt pretty feverish. And of course, you can't ignore that history of COPD. That's a huge piece of the puzzle right from the get-go.
With the patient story on the table, the clinical detective work can really begin. This is where the team starts gathering those first objective clues to figure out, what's really going on under the surface.
It all starts with a simple conversation. But hey, this isn't just any old chat. Clinicians use really structured questions to build a complete and detailed picture of the illness, making sure that absolutely no critical information gets missed.
And a really clever way they do this is with a simple mnemonic called "What's Up?" This framework is a fantastic guide for asking all the right questions, from where is the problem and how does it feel, all the way to understanding what the patient thinks is going on. It's just a super smart, systematic way to make sure they get the full story.
All right, so after all that talking, it's time to get hands-on, and the very first step is simple observation, or what they call inspection. The clinician is just looking for visual clues. Is his chest moving evenly when he breathes? What's his skin color look like? Is he using extra muscles in his neck or chest just to get air in? These are all classic, telltale signs that someone is really struggling to breathe.
Next up is palpation, which is really just a fancy word for using touch. Here, the clinician might put their hands on Mr. Granger's back to feel for what's called respiratory excursion, which is just their way of checking how much and how evenly his chest is expanding every time he takes a breath. It gives them a real sense of the mechanics of his breathing.
And then, of course, we get to the part everyone recognizes: auscultation. This is when they listen to the lungs with a stethoscope. They're basically tuning in, listening for the quality of the breath sounds, and more importantly, listening for any sounds that just shouldn't be there.
And boom. In Mr. Granger's case, they hear something specific. They're called crackles. The sound is kind of like rubbing strands of hair together right next to your ear. So why is this such a big deal? Well, this specific sound suggests there's fluid down in his small airways. That is a huge clue that points right to the source of the problem.
Okay, so the physical exam gave us some really important clues, but now it's time for the hard data. This is where we look at the numbers from his vital signs, and let me tell you, the story these numbers tell is pretty alarming.
Wow. Yeah, these numbers really paint a picture of just how much distress he's in. I mean, look at this. His temperature is up at 101.8, his pulse is racing at 102, and his breathing rate, a whopping 32 breaths a minute. That's way faster than normal. Basically, every single one of these numbers is just screaming that something is seriously wrong.
But out of all of them, this number, 86% oxygen saturation, this is the real showstopper. A healthy person should be at 95% or higher. This tells the team that Mr. Granger's body just is not getting the oxygen it desperately needs. This isn't a wait-and-see kind of number. This demands action, right now.
Okay, so with an O2 level that low, there is absolutely no time to waste. It is time for immediate action. Right now, the goal isn't even about getting a final diagnosis. It's about one thing: stabilizing him.
So what's the first move? It's simple, direct, and crucial. Get him on some oxygen. In this case, it's 2 liters per minute through a nasal cannula. It's a really simple, straightforward way to tackle that dangerously low oxygen level head-on. And look at that. This just perfectly shows the immediate impact. His oxygen saturation quickly jumps from that critical 86% up to a much, much safer 92%. That's a fantastic response for sure. But remember, we've only treated the symptom. The underlying problem, that's still there and needs to be figured out. So Mr. Granger is doing better. He's more stable, but he is definitely not out of the woods. He needs a higher level of care. And this brings us to what is honestly one of the most critical moments in a patient's entire journey, the handoff to the emergency room team.
You know, this next step is so important. I mean, think about it. How do you make sure all this crucial info gets passed along correctly without anything falling through the cracks? Well, to do that, healthcare teams use this amazing structured tool called SBAR. SBAR stands for Situation, Background, Assessment, and Recommendation. Let's break it down. The S for situation is just a quick, clear summary to get everyone on the same page fast. So for Mr. Granger, it's quick and to the point. Mr. Granger came in for an appointment today for increased shortness of breath.
All right, next up is B for background. This gives them all that essential context, the need-to-know stuff. He is 67 years old with a history of COPD, and his current list of medications is also provided. This gives the team in the ER the backstory they need.
Then we have A for assessment. This is basically the here's what we found part of the report. Mr. Granger was hypoxic on arrival, but his O2 sat is now up to 92% on 2 liters of oxygen. It also includes those crazy vital signs and, of course, that all-important finding, those crackles in his lungs.
And last but not least, R for recommendation. This is the so what are we going to do about it part. It's a super clear, direct call to action. Patient to be transferred to the ER for evaluation to rule out a COPD exacerbation. No guesswork, no ambiguity. Everybody knows exactly what the plan is.
And, this whole case just perfectly illustrates that effective healthcare isn't just about what you know, but how you communicate it. It's built on this kind of invisible framework, these amazing tools like SBR that are working constantly behind the scenes. So the question I really want to leave you with is this. How often does this disciplined, structured communication ensure patient safety, turning potential chaos into a clear, coordinated plan of care every single day?